It will be my pleasure to introduce the first speaker, Professor Richard Nethononda, who's the academic head of cardiology at Crisani Baragwana Hospital at Wits University, a member and fellow of the American College of Cardiology. Unfortunately, Professor Richard Nethononda could not be with us. He's going to do it virtual because all the cardiologists that both Professor Mokwala and Dr. Mbagaza wanted to approach in Gauteng are sitting as we're talking now at the European Society of Cardiology meeting in Amsterdam in Netherlands. So Professor Nethononda accepted even in Netherlands to talk to us through virtual. So Richard, thank you for that. The floor is yours.
Thank you, Willie, and the South African Society of Nuclear Medicine for the invitation. I am going to give an overview of sarcoidosis, and I will end by touching on the cardiac manifestation of this disease. As a cardiologist myself, I have got nothing to declare. To begin, the disease was described more than a century ago. It's a multi-system disease of unknown cause. And like anything that we don't know much about, there is often a lot of speculation. But really, there is an interplay between a possible infective agent, the genetic makeup of the individual, as well as the environment. It usually affects young and middle-aged adults. It has got a variable incidence depending on the geography, up to 64 patients per 100,000 if you are in Europe, and up to 35 people per 100,000 if you are in North America. In South Africa, over a 10-year period, Raj Murar and his colleagues at our institution found sarcoid in up to 23 persons per 100,000 in institution. There is a slight female predominance, particularly amongst African and Asians. And in areas with tuberculosis, including within our region, the similarity of this condition with tuberculosis often leads to misdiagnosis and is possibly responsible for the underreporting of its incidence. It commonly presents with respiratory symptoms, particularly cough and shortness of breath, and also skin lesions. Thus, in general, the pulmonologist and dermatologist are the first clinicians to come into contact with this kind of patients. However, other organs, including the liver, the spleen, the salivary glands, the heart, the nervous system, and the eye are often involved. And really the disease process or the disease manifestation is as a result of functional disturbance of tissue and organ function, as well as subsequent fibrosis. So really the destruction that eventually results from this granulomatous inflammation caused by this condition. It's a multi-system disorder of diverse manifestation. And as I've said, it presents to different specialists, first presentation. And the duration of illness, the site and extent of organ involvement, as well as disease activity, it's of a factor of ethnicity. Constitutional symptoms occur in about 30% of cases, and that include fever, fatigue, malaise, night sweat, and so forth. And these tend to be common in people of African and Asian descent. The respiratory features, cough, dyspnea, chest pain, and hemoptysis, and lymphadenopathy, particularly the cervical, axillary, trochlear, inguinal areas. And these glands are mobile and are usually non-tender. And the heart is involved in up to 30% of cases from both CMR and post-mortem studies. Whilst in 80% of cases, there are granulomas in the liver, but hepatomegaly is seen in only 20% of cases. The skin is involved in 27% of cases, and mainly as erythema nodosum, which is really lesions that I will show at the next slide. Papulonodular rash, lupus pinea, which is quite characteristic. And of course, this can lead to disfiguring of the face. In the eyes, it often presents as uveitis that can involve all the layers. And the nervous system, in general, non-specific, but we'll touch on it later on. Large and small joints can be affected and presents as acute pain, which is transient, that can be chronic as well, myopathy, as well as bone lesions. The salivary gland is uncommonly involved, and it would be enlarged. The endocrine, manifesting as hypercalcemia, hypercalciuria, and diabetes insipidus. And of course, where you've got hypercalcemia and hypercalciuria, you tend to complicate with nephrocalcinosis as well as renal stones. This is a table from our institution, Raj Murar and his colleague series, just really showing the involvement. And you can see that the lung is involved in the majority of cases, followed by lymph glands, the skin, the eye, as well as the bones and joints. The liver, hepatomegaly in 10% of cases, splenomegaly slightly below 10%, both liver and spleen in about 7%, the heart in about 3%, copulmonale really a results of burnout disease, heart block in 1%, and the various neurological involvement. Renal stones we touched on, the parotid gland, and so forth. This is the typical skin features. This is really a severe form of papulonodular skin involvement. You can see it here and there. This is erythema nodosus. And of course, down here, this is lupus pinea. You can see it's very, very, these pink raised lesions that are very, very destructive, affecting the facial parts of various parts of the face. The lungs can be involved, even though the lungs radiographically may appear normal. We know that when you do a CT scan, often you find extensive disease. But classically, these have been the various stages of lung involvement, starting with stage 1, where you've got bilateral lymphadenopathy, stage 2, where you've got a combination of lymphadenopathy as well as lung involvement, stage 3, where there is mainly lung involvement with lymph glands disappeared or calcified, and stage 4, where you've got fibrocavitary changes really bad out disease that can lead to cor pulmonale. The diagnosis of this complex disease is made really by a combination of compatible clinical features together with characteristic radiological features, as well as histology showing non-caseating epithelial granuloma. And of course, if you are in our environment, you should be careful to exclude all other causes of granulomatous inflammation, particularly tuberculosis. Tissue diagnosis is the tissue is obtained quite simply from a skin biopsy where you've got suspicious skin lesions and where the lungs are involved without any peripheral organ. We often do a transbronchial biopsy of the lung tissue. We can also do a mediastinal lymph node biopsy using a technique of mediastinoscopy. And of course, in instances where the heart is involved solo, then we do endomyocardial biopsy to confirm the diagnosis of cardiac sarcoid. This is a sketch plan that I took from a recent publication in May from the European Heart Journal, really outlining the progression from pathogenesis, clinical manifestation, as well as the diagnosis, and ending up with the survival in patients with cardiac sarcoid, as well as touching on therapy and factors that influence prognosis or outcome of this disease. The cardiac manifestation of sarcoid, in short, include AV blocks and ventricular tachyarrhythmias. The VTs have got multiple morphologies. Patients can present with mitral regurgitation from granulomatous destruction of the CODI as well as the valve apparatus. RV involvement may look pretty much like arrhythmogenic right ventricular cardiomyopathy. Patients can present with angina pectoris due to impairment of coronary flow reserve, as well as in fact having a true coronary involvement by way of arthritis. And patients can present with MINOCA, which is really myocardial infarction without occlusive coronary artery disease. They can have dissection or indeed organic single vessel narrowing causing myocardial infarction. I took this again from the same publication, comparing the presentation of cardiac sarcoidosis from North America with a Finnish cohort. As you can see, dyspnea, palpitation ranked high, followed by fatigue, chest pain, pre-syncope, syncope, edema, and cardiac arrest in the North American cohort, whereas in the Finnish study, they mainly had high-grade AV blocks, heart failure, sustained VT, and of course, a non-sustained VT or premature ventricular beats, aborted sudden cardiac death in 4%, and so forth. How do we then make a diagnosis, or what tools do we have to investigate cardiac sarcoid? Of course, the first thing that we do as cardiologists is an ECG, which can look pretty normal. We then do an echocardiogram, which can also look normal, but I will touch on, what do we find when we do find something. And really the gold standard for us is a cardiac MRI, as well as a FDG PET scan. And lastly, we can do endomyocardial biopsy where the diagnosis is still uncertain. A 12-lead resting ECG will often show AV block where there is, where it does show something, prolonged QRS complexes, complete bundle branch block, abnormal Q waves, T wave inversion, frequent premature ventricular beats or epsilon waves. And as you see, any cardiologist will tell you that this is really pretty much non-specific. Echocardiography, often there could be LV dysfunction with an EF lower than 50%, LV wall thinning, thickening or thinning, localized akinesia, dyskinesia, aneurysm, features that really, could be found also in patients with arrhythmogenic ventricular cardiomyopathy, reduced global longitudinal strain, RV enlargement and reduced RV strain, pericardial effusion, again, fairly non-specific. This is a patient that presented to us, a 42-year-old female who collapsed and had a near-death experience while training at the Vision Active, and was fortunate to be resuscitated and eventually was sent to me for MRI imaging. As you can see, the black is normal myocardium. This is an LVOT view or 5-chamber view. As you can see, the anterior wall is white there, which means fibrosis. This is a short axis view. Again, the black is normal myocardium. The white, it's a fibrosis, really appearing like that because of gadolinium that stays longer in fibrotic tissue or where there is expansion of the interstitium. And in this 4-chamber view, again, you can see epicardial fibrosis there, pretty much like, the classical hook sign, really, where there is a septum, the apical wall. So very extensive fibrosis that do not follow a coronary pattern that affects both the epicardium and endocardium, that is transmural, really multiple segments of the heart. And that is quite fairly typical of this condition. It's really only this condition that can give you this extensive amount of fibrosis in this manner. This is I took this from the European Heart Journal. This is a FDG PET scan showing in A, these are areas of activity. These are lymph glands. And in B, again, this is a 4-chamber view of the heart. And the arrow really shows, the white arrow shows areas of activity, areas of activity there in the apex, in the basal inferior wall, in the septum. And this is the perfusion scan, again, that I'm talking to the converted here. The septum, there is a defect there, in that view. Basal septum, there is a defect, and septum at that level, there is a defect. So you can see really the beauty of this kind of imaging is that you're able to synergize what you see both at the level of the scan and metabolism as well as perfusion. Endomyocardial biopsy, when we do it, we know that there is 1% risk of serious adverse events. It's got low sensitivity simply because of sampling errors. But if you combine it with PET imaging, sensitivity improves. What we really want to see on histology, we want to see non-necrotic granulomas with isolated giant cell, with or without lymphocytic. The disease evolution, it's got a variable course with spontaneous remission in up to 66% of the case. In the other third of cases, the disease is chronic and progressive. Mortality from the disease is 1 to up to 5%, and death is due to respiratory failure, cardiac involvement, or central nervous system involvement. The management of sarcoidosis, there are no really complete data from randomized control trials comparing various treatment options. I know 1 or 2 trials that are ongoing at the moment. As we stand, really the treatment is empiric, depending on the clinical manifestation and the evidence of disease activity, from imaging as well as from histology. Steroids remain the mainstay of treatment. However, other immunomodulators can be used when the patient can't still tolerate steroid therapy with high dose. Of course, ICD, like in the patient that I showed earlier, the young lady, we had to put an ICD because of the near-death experience, as well as the extensive fibrosis we saw on late guard imaging. But whenever the LV ejection fraction is less than 35%, really as per current guideline, ACC or ESC, we would put ICD in a patient with heart failure from sarcoid. Alternatively, when the patient has got high-grade AV block and we have to put a pacemaker, we'll put a pacemaker with ICD capabilities. End of my talk. Thank you very much. And once again, Prof. Ango and the South African Society of Nuclear Medicine, thank you for inviting. Thank you.